A seat and we'll get started on our healthcare program. Yeah, right. Or a countdown or something. Yeah. Okay, well, we're going to get rolling here. I am Roger Stark. I'm the healthcare policy analyst at Washington Policy Center. And let me take this opportunity to thank you for coming out to our Solutions Summit today. I am in the Seattle office, but today I've seen a lot of familiar faces over here in Spokane and really appreciate the fact that you've come out to support WPC and to learn something as we go along here through today's activities. One of my favorite comedians was Will Rogers. He was a political humorist, and Will used to say, it's really easy to make political jokes. All I do is watch the government and report the facts. And so the fact is, folks, that Governor Jay Inslee signed the public option into law yesterday. Washington State, we are the tip of the spear as far as public option is concerned. It is not a single payer, but it's an incremental move towards a single payer. Now, the best defense is oftentimes a good offense. The best offense is oftentimes a good defense. And I think it's good that we would know about what we're going to be defensive about as far as healthcare is concerned. Yogi Berra, the famous baseball player, used to say, when you come to a fork in the road, take it. And so that's what we're at, folks, is the fork in the road. We can either go down more government in our healthcare delivery system, or we can go down the path to more patient control of their own healthcare decisions and their own healthcare dollars. And obviously, WPC, we're a free market organization. As far as healthcare is concerned, when you talk about free market, that means putting the patient in charge, not government bureaucrats. Now, for over the last 20, 25 years, our sister think tank in Vancouver, British Columbia, the Fraser Institute, has looked at wait times as far as Canadians are concerned. The poster child for single payer is Canada. It always comes up in discussions of single payer. Canada can do it. The United States should be able to do it as well. So we thought, well, let's just fact check some of this stuff. Let's see what really is going on in Canada. So we brought here this afternoon one of the leading experts on the Canadian healthcare delivery system, wait times, and specifically the cost of those wait times. It is my pleasure to introduce Dr. Stephen Globerman, who actually was one of the original authors back in the 90s of these wait times that are done annually by the Fraser Institute. Dr. Globerman is the Addington Chair of Measurement and a Senior Fellow at the Fraser Institute. He also is an Emeritus Professor of Economics at Western Washington University. And when I first told someone that Professor Globerman was coming, they said, well, my gosh, he must be the only conservative free market guy at Western Washington. I don't know if that's exactly true, but we'll perhaps find out here this afternoon. Dr. Globerman has released over 200 in-depth papers on not just healthcare, but also issues dealing with international trade, with investment, with regulations, and antitrust. Dr. Globerman holds a PhD in economics from New York University. He has held tenured faculty positions at York University in Toronto and Simon Fraser University in Vancouver. And he's been on the visiting faculty at the University of California, the Stockholm School of Economics, and the Copenhagen Business School. Please join me in welcoming Dr. Globerman.
Well, thank you, Roger, and you anticipated a number of my comments to start with. Timely to be here. Thank you for being here. Apologies in advance for maybe some dense PowerPoints. I'm an insecure speaker, so I like to have everything there. I can look and make sure I'm not missing any points. So the issue that I was asked to speak about is Canada's single-payer healthcare system right for Washington State? And I start out by saying, is this the right question to ask? Roger mentioned that we now in Washington State have not single payer, but we have a government proposal, government insurance plan. Public and private insurance are somehow going to coexist in the state. I think that's a question that we can ask. Can they coexist? And in a little while, I'm going to elaborate on that and say it's possible, but it's challenging, and it's more likely than not that that's not a long-run steady state equilibrium, that ultimately you do wind up with something much closer to single payer than to a dual paying system. But we do have some experience in Massachusetts, as you know, because Romney Care became, in some sense, the model for Obamacare. It did have a dual system where you had private and public insurance, health insurance available. The reason I say is it feasible to have a single payer system in a single state is really an issue, because you have a tax base that's mobile, and if you're taxing to provide health insurance and the adjoining or contiguous states are not, you're creating an enormous incentive for high-income taxpayers to leave the state, businesses to leave the state, particularly if you're imposing payroll taxes to pay for the insurance. You also have an interesting issue about who's going to be a resident, and you have a lot of monitoring to do, because, and even this is true even at a national level, by the way. Canada has some interesting issues that it's confronting, where it has people who are living in Canada but working outside of Canada, not paying taxes, and not paying essentially for the health care that they're getting under the government health care plan. Well, at a state level, obviously, you've got a lot more mobility, and you've got a lot more opportunity for people to work in one state but somehow claim residence in another state. So it's not a trivial issue. And the one attempt to really have single payer in a state was Vermont. That was the closest try. Why Vermont? I'll get to Bernie in a minute. The Green Mountain Care 2011 proposed legislation where all residents of Vermont would receive universal health care, paid for essentially through taxes, which we'll see is the Canadian system, particularly payroll taxes, which is not the Canadian system. But employees could choose to keep employee-sponsored plan. The plan was abandoned in 2014, wasn't implemented. The main concern was tax leakage, the threat of businesses leaving the state, and also the point I made earlier, administration of residency requirements, which is not trivial. So to me, the relevant question is, in the long run, should Washington state residents support essentially a federal single-payer healthcare plan? And then to answer that question, we have to address two other questions. What would it look like? What would this national, this federal single-payer system look like? And then, is it a good idea? So let me give you a little bit of a preview of what I'm going to say, because what I am talking about is Canada, because Canada is the model. Now, I understand that we're getting all kinds of proposals now from the Democrat Party as to what, quote unquote, a single payer system would look like. Is it really going to be single payer? Maybe it's a dual payer. If you like your insurance, you can keep your insurance. If you don't like your insurance, you can get our insurance, you know, that whole thing. But as I said before, I think anyone who is thinking along the lines of, well, maybe there's some hybrid model, you have to accept the likelihood, if not the certainty, that ultimately you're going to wind up with single payer, and I'll elaborate on that a little later on. So Canada is single payer in any conventional sense of the word. Although it's not as simple as a lot of people who are concerned about single payer want to make it sound. And that's maybe the takeaway that I'm going to preview, because that is what I think the takeaway is that I want you to have, is that when you're entering in this debate, you want to avoid cherry-picking data or choosing particular aspects of the performance of one system versus another. It's a general equilibrium. So to anticipate a point I'm going to make, just to illustrate what I'm saying, is I'm going to show you a lot of data that makes Canada look pretty good. And it looks pretty good for reasons that are often outside the healthcare debate. Canada looks pretty good in healthcare performance, but Canada's economic growth rate is not very good. Canada's innovation performance is not very good. Part of the reason is very high marginal tax rates that are needed to pay for single payer. And high marginal tax rates discourage growth and they discourage innovation. I'm not talking about healthcare strictly now. I'm talking about in general, in the economy, in the private economy in total. So my point is that if we're going to be engaged in this debate, and we're going to be intelligent in engaging in this debate, we can't just cherry pick and just look even just at the healthcare sector, because the healthcare sector is part of a larger economy, and the effects from the healthcare sector have general equilibrium effects in other parts of the economy. And I'll get to that in a moment, but first I'll give you a quick preview of the Canadian healthcare system, and I apologize if this is old news to any or all of you. The Canadian healthcare system essentially is a single-payer system administered by provinces, but the provincial governments receive a substantial amount of funding from the federal government under something called the Canada Health Transfer, which is a subset of the Canada Health Act. Now, the reason this is important is because even though the provinces, in principle, are managing their healthcare insurance programs, they're under the thumb of the federal government, because that 25% or so funding that comes from the federal government gives the federal government a lot of leverage in terms of what the provinces can do. So what you don't have in Canada, which is one of the aspects of having a single payer like the Canadian system, is you don't get experimentation and innovation at the provincial level, because the provincial governments are very worried about stepping outside the boundaries of the Canada Health Act and losing that federal money. And I'll get back to that in a little while. So we have healthcare in Canada that's funded through general taxes, essentially the income taxes at the federal and the provincial level. And I mentioned a little while ago that one of the consequences in Canada of having this type of healthcare insurance system is high marginal tax rates. So I'll just give you a number just to put this in context. If you live in the province of Ontario and you make 150,000 Canadian dollars a year, which is, let's say it's around 112, 115,000 US, you're in the 52% marginal tax rate, which is a very high marginal tax rate. Okay, well, that's part of the story. And that's part of the story that gets told, but what I want to reinforce is that those high tax rates have effects in other parts of the economy. Health insurance must be provided by provincial governments to all legal residents. And they're very good at providing health insurance to all legal residents. My daughter moved to Ontario in a couple of summers ago, and she got health care, and within 2 months she was fully covered by the province of Ontario. So I mentioned it's tax funded. How much? About 24-25% of the total tax revenue collected by the federal and provincial governments in Canada go for health care, and 40% of program spending. So if we take out all the redistribution that goes on, the government does unemployment insurance, disability insurance, take all of that, just focus on what the government's spending to deliver services to the population, and then about 40% of provincial funding goes for health care. It's free at the point of care. There's no co-payment. There's no deductibles. Canada and the UK are unique in having no cost sharing at all at the patient level. The provinces insure what's called medically necessary services. I'm going to call them basic services. I'll use those terms interchangeably. Who decides what's medically necessary? Well, the provincial bureaucracy, the health ministry decides. But they have to be mindful that if their definition is too narrow, the federal government, the Ministry of Health in Ottawa might say, no, you have to cover X, Y, and Z. I'll give you the Canadian version of Z. You have to cover X, Y, and Z, or you lose your federal transfer money. And there's a lot of uncertainty about what's basic service, obviously, but that's a bureaucratic call. And that's one of the differences between government-provided health care and private health care, private insurance. And you're going to have bureaucrats deciding what's basic and what isn't. There's gatekeeping. You can't see a specialist directly. You have to have your general practitioner refer you to a specialist. There's little or no private options for treatments that fall into the basic care category. And in a minute I'll elaborate on that. But this is a very important point, because you might say, okay, well, what if I want to pay out of pocket? What if I just want this treatment and I want to pay out of pocket? Well, in Canada, it's illegal for healthcare providers who are being paid by the government to also bill their patients in addition to, right? If you treat someone and you're going to be paid by the government, you can't turn around and say, oh, by the way, I'm going to ask you for another $50 or whatever. That's clearly illegal. What's in the gray area right now in Canada is whether, if I'm a healthcare provider, can I just opt out completely and say, I'm not going to charge the provincial ministry anything. I won't take a cent from the provincial insurance plan. I'll just work privately. That's a gray area, because under the Canada Health Act, the federal government can stop paying the provinces if the federal government deems certain practices going on in the provinces are interfering with access to health care for people who are covered by the government plan. So if you had, in the extreme, say every doctor in British Columbia saying, I'm not working for the provincial healthcare plan, I'm working privately, that wouldn't last for half a second. The government would say, can't do that because we need you to work for the provincial insurance plan. So there are some lawsuits going on now, particularly there's a major one in British Columbia where radiologist who started a bunch of private clinics and is doing a lot of business and doing a good business is being sued by the province for reducing access to care in the public sector. But maybe I'll save the rest of that for question and answer. The other feature I want to mention is that there are drugs are only covered if they're provided inpatient. So in the hospitals, the insurance plan will cover pharmaceuticals, but outside the hospital, you're an outpatient. The provincial plans in Canada do not cover drugs under those circumstances. People are usually covered through their employer for pharmaceuticals. But there are a lot of regulations in Canada around pharmaceuticals, and there are effectively price controls. And I can go into the details in the question and answer. The point I would make here is that we're hearing a lot of rhetoric, even from the Trump administration, about adopting some of the same types of price controls that Canada has, and allowing drugs to be imported from Canada would be effectively indirectly importing Canada's price controls, and that has implications for access to drugs. Okay, so there's no private insurance for medically necessary or basic health care And as I said, providers who pay through the government plan can't bill privately. The Canadian plan doesn't cover dental, it doesn't cover vision. It covers outpatient pharma, but not inpatient pharma. So it's not 100% coverage. And that's important because because when we hear people say Canada has a socialized medical system, it's true for certain parts of the system, but not others. So here's a summary of the main features of the Canadian system, and I've covered most of them. I think it's useful to keep these in mind because, and I'm going to use Bernie Sanders' plan as the example to talk about. He makes some arguments about why the Canadian system is a good system for Americans, and these are basically the arguments that one usually hears, that it covers everyone. That's a good thing. That it's user-friendly, that you don't have to deal with deductibles and co-pays. There's no paperwork. If you're a patient in Canada, you go in and see your doctor, you get what's needed to be done, and you're done. There are administrative efficiencies for the healthcare providers. They're dealing with one single insurer, and it's all electronic, and it all works. And the administrative costs of the Canadian system, the direct administrative costs of the Canadian system, are relatively low, and that saves money. It also provides bargaining leverage. If you're the provincial government, you're bargaining with all the healthcare providers. You're bargaining with the doctors and the nurses. You're bargaining with the pharmaceutical companies about what you're going to pay for drugs. And so there's real leverage, and that leads to lower input prices. Now, as an economist, I would say we want competitive prices. We don't want what an economist would call monopsonistic prices. But if you're if you're worrying about spending, that's one way to save money. And in principle, it separates the quality of care from the availability of care, because, as I said, you really don't have a two-tier system in Canada. The private provision of basic health care doesn't exist, so everyone has the same type of health care. That seems fair, right? I mean, that's what Bernie would say. It's fair that everyone has the same type of health care. Money shouldn't buy you better care just because you can afford it. Okay. So Bernie went on a voyage of discovery to Canada, and Canadians love nothing more. Let me tell you, they love nothing more than American politicians coming and telling them what a great job they're doing. You know, it's a validation. So what did Bernie think he learned from his one-day visit to Toronto? Well, he learned that the Canadian system is equitable. And that's why he's favoring the single-payer system. He was apparently quite impressed by the fact that Canadians seem to value equity over efficiency. And Mark Pauly, who's a very famous health economist, basically said, well, you can't import other people's values. I mean, even if Canadians only cared about equity, Americans don't necessarily share that value, so that's an insufficient reason to import the Canadian healthcare system. Well, I was telling Roger, I've lived half my life in Canada and half in the US. I'm a dual citizen. I consider myself pretty fluent in the culture of both countries, and I can say that both are caricatures. The Canadians certainly care about efficiency. They certainly worry about how much they're paying in taxes to support their healthcare system. They do value choice. They do value good service. And I would venture to say that most Americans care about equity, not just efficiency. So what we're looking for is a system that's both efficient and equitable. And I guess then the question is, okay, well, so is the Canadian system efficient and equitable? Is it more efficient than the US system? So that's where I'm going with this right now, and I'm going to talk about different metrics that you often hear in this debate when people are comparing healthcare systems as one better than the other. Expenditures. And people often use expenditures as a proxy for efficiency. And what I want to say quite clearly is expenditures are not a proxy for efficiency. Expenditures tell you nothing about how much people value what they're getting per dollar spent. And it also doesn't tell you what the quality is per dollar spent. It's what it is. It's expenditures. How much did you spend? Well, does it tell you anything? Sure. It tells you essentially what the value of the real resources are that you're using to provide one thing rather than another. All other things the same. Obviously, you'd rather get the same output and spend less. Well, another measure that people look at is, okay, well, what are the resources that you're putting into this system? And resources are inputs. So again, you know, you might have more doctors per capita than some other country. Does that mean that you've got a better healthcare system? Not necessarily. Maybe you've got, nothing personal, I know you're a great doctor, but you know, some doctors are better than others. And what are you getting for the service? How long are you waiting for the service? So resources tell you something, but again, they don't tell you everything, and they can be very misleading if you don't use the data correctly. And then finally, outcomes. Well, maybe outcomes tell us something. How long are people living? How healthy are they? What's the morbidity of the population? And again, even here, you've got to be careful, because if you start out with different populations, you can have different outcomes that have nothing, well, I wouldn't say nothing, but have much less to do with the actual healthcare system than other things that are going on in the economy. The housing stock, the education level. Educated people are healthier than less educated people. I mean, you got a general equilibrium system. So I'm going to show you some data, but I want you to keep all these caveats in mind when you look at these data. And as I said, and I warned you, when you look at these data, Canada's going to look pretty good, and you have to dig below the surface of these data to really make an evaluation of whether all of us want the Canadian system. Okay, let's look at expenditures, and we don't have to dwell on these numbers. This is well known. The U.S. is the most expensive, quote-unquote, healthcare system in the OECD, which is all the rich and not so rich countries in the world. So the U.S. is spending about 17% of its GDP on healthcare, and Canada's spending about 10%. 10.5% of its GDP on healthcare, and it looks like the U.S. is a big, and this is, you very often hear, right, this is one of the arguments that people make for changing the healthcare system. Look at how much we spend. Is this sustainable? Can we keep doing this? The only point I'd highlight here is that Canada's not the cheapest place, at least in terms of how much it's spending on healthcare. It ranks 8th in the OECD. So Canada spends a lot less than the U.S., but spends more than a lot of Western European countries. Okay, well, maybe you don't like GDP as the denominator to scale healthcare expenditures. So if you look at another measure of expenditures that people often look at is expenditures per capita, expenditures on healthcare per person, and these are PPP adjusted exchange rates. We don't have to go into that. It's taking into account differences in cost of living across countries to try and get a finer comparison when you convert from all other currencies to US dollars. Again, the US ranks first, and that difference between the US and Canada is pretty impressive. That's more than double. US spends more than double per person on healthcare compared to Canada. This is all healthcare, right? This is everything. This isn't just basic healthcare. This is pharmaceuticals. This is all the rest. Canada is within one standard deviation of the mean when you have a sample of OECD countries. The U.S. is more than 3 standard deviation units to the right of the mean of all OECD countries. We spend a lot of money on healthcare. One would hope that we get results from Okay, well, let's look at inputs. Maybe we're buying a lot more inputs than Canada is. And here's one measure, and I hope you can see it. And if you can, I'll just give you the highlight here. If you look at physicians per thousand population, and now I'm looking just at the rich OECD countries, taking out Mexico and Turkey and countries that you might say, okay, well, let's not compare. Let's just look at the rich countries. We're down at the bottom of the list in terms of physicians per thousand population. Canada's not much ahead of us, neither is the UK. We've got Norway and Switzerland up at the top with almost twice as many physicians per thousand population. I won't go into the reasons for this, but we can raise this in the question and answer period because it is a pretty striking statistic. Well, okay, well, we're spending a lot of money. We're not getting a lot more doctors per capita. What are we getting for the money we spend? Well, I don't know if you can see this, and I apologize if you can't, but this, I didn't cherry pick these data, but I obviously have to limit the number of slides. So I'm looking at MRIs, magnetic resonance imaging machines, per million population. Again, at rich countries, and the U.S. is right at the top. And the U.S. ratio is almost 4 times as high as Canada's. And by the way, if you spend time in Canada, you know that getting imaging done quickly is a big problem in Canada. And that's why this case I mentioned a while ago where this radiologist started private imaging clinics in Vancouver, why it's so popular in Vancouver. This is an area where we can say, yeah, we're spending a lot, and we have a lot of MRI machines per capita, and we also have a lot of PET scanners per capita, almost 4 times the number of PET scanners per capita. Okay, what about pharmaceuticals? Well, the U.S. spends a fair amount on pharmaceuticals. This is expenditures per capita in U.S. dollars, and Canada's up there, but well below what the U.S. is. And by the way, I'm going to get to this in a minute. Americans have access to new drugs about a year in advance of Canadians, in part because of Canada's price controls on drugs, which discourages manufacturers from moving drugs into Canada. And I can tell you that pharmaceutical companies are going to be very, very concerned if the U.S. government allows direct importation of drugs from Canada, because the price of drugs in Canada are much lower than they are here. Okay, so what's the summary? The summary is the U.S. outspends Canada, but Canada outspends a lot of other rich countries. The U.S. particularly outspends Canada on technology and on pharmaceuticals. The other point I would make is that while Canadians and Americans have about the same access in terms of numbers of physicians per person, Canada has more general practitioners relative to specialists. The U.S. has more specialists relative to general practitioners. There's essentially a different philosophy of delivering medical care in Canada, much more emphasis on preventive care, and that shows up in the breakdown of physicians. Okay, well, let's look at outcomes now. So now, are Americans getting better outcomes for the amount spent? Well, okay, so what are you going to choose as outcomes? You can choose all kinds of things. The standard things that people choose, as I mentioned earlier, longevity. So I've used female longevity to take out of the picture kind of the male opioid problem in the U.S. and car accidents and shootings, which primarily affect males as opposed to females. But I do have an all-birth longevity measure as well. The takeaway here is that Canada actually does better on longevity measures, and even if you take out external causes, so I've got a row in there, deaths net of external causes per 100,000. So that's taking out gun mortality, drug mortality, road accidents. It's trying to get closer to what might be called a medical problem. Well, even here we see that Canadians have fewer deaths per 100,000 than Americans do in diabetes. It's no surprise Canadians have lower diabetes rates. But I'm hustling along here because I know we want to get to the question and answer soon. But one of the reasons you have problems in comparing countries is that Canada has a very high percentage of Asians living in the population. Asians are thin, they don't get diabetes. So, again, if you're making these comparisons, you want to hold everything constant, which is hard to do. Okay, here's some outcomes from cancer treatments, which you would think the U.S. would do pretty well on, and we do. But Canada's not far behind, even in areas where the U.S. is doing better, and in some cases Canada's doing better than the U.S. For example, in leukemia, net survival rates, Canada is doing better, and it's doing actually pretty well compared to other OECD countries. Well, okay, so this is a bit troubling, right? I mean, here's a little more data that continues to be troubling. Look at some of the things like asthma and congestive pulmonary disease. These are hospital admission rates. The U.S. admits more people for those and a lot more for congestive heart failure, which suggests that maybe we're not doing as good a job in terms of primary care. Okay, I'm going to hustle along. Canadians think they're in good health. There's no evidence that Canadians think they're a lot less healthy than Americans. In fact, if anything, it's the other way around for both males and females, both young and old. Canadians think that they're in pretty good health and seem to exceed Americans in that. Okay, so what's the broad takeaway here? Canada spends less on healthcare, has better longevity measures, better mortality measures, clinical outcomes, not obviously worse across the board than in the U.S., perceived health status better than in the U.S. Well, what's going on here? We can make the story even more perplexing. Here's access related to cost sharing. This is OECD data. And what this data is saying is in the U.S., more people skip doctor's appointments, medical tests, skip taking their drugs for financial reasons compared to Canada, compared to Canadians, which is not entirely surprising if you have co-pays and deductibles in one country and not another. Just more grist for the mill for people who are worrying about this first, worrying about Canadian system. And here's the Achilles heel of the Canadian system. It's wait times. This is OECD data. So this is the number of the percentage of patients waiting more than 4 weeks for an appointment with a specialist, in Canada's way at the top and way, way higher than the U.S. And that's the statistic that everyone wants to look at, who wants to make the argument that single payer is a terrible idea. And you've got the data, there it is. And you can add to that percentage waiting more than 4 hours in an emergency department. And Canada, again, is down at the bottom of the list. Although I would point out that the U.S., I didn't cherry pick this. This is just, these are a select sample of countries, but I can tell you that I got the two bottom ones now, the U.S. and Canada. Wait times, so here's finally wait times for what are Canadians waiting for. These are wait times to be treated by a specialist for different types of conditions. And what I want to highlight in this, because this is, and I've lived in Canada, so I've lived this experience. If you're suspected of having cancer, and you may wait to get scanned, but if you're suspected of having cancer, you're going to go to the BC Cancer Care quite quickly. If you're waiting for a hip replacement, you can wait forever. So there's triage in the Canadian system, and that's an important feature. And the triage is means that bureaucrats get to decide who goes first, which conditions matter more than others. So does waiting matter? Roger mentioned that the Fraser Institute has done some work on this, and I've done some work on this. How much does waiting matter? Some people say it really doesn't matter very much because a lot of people will just sign up for things that they don't want, or doctors will double or triple book their patients with specialists to make sure that they get the first opening available. We tried to estimate how much waiting matters in terms of lost work time and then attach a dollar value to that lost work time. And we come up with a number that's not trivial, but it's not large relative to Canada's GDP. It's about 1%. Of course, that's a very conservative measure of cost of waiting, because there are many doctors in Canada who would say, people's health care is compromised by waiting, and you have literally people dying on wait lists. But that's very hard to prove, and particularly when I showed you that slide just a minute ago, which shows that for really morbid conditions like cancer, and you can generally get treated much more quickly than if you're waiting for non-morbid type conditions. Okay, so Bernie thought access to healthcare in Canada is very equitable. Is it very equitable? Yes. Is it perfectly equitable? No. People can get healthcare outside Canada. How many people do? Here's one estimate that I have. About 200,000 Canadians in 2017 sought healthcare outside of the country. That's 36 million people in Canada. That's not a large number of people who are going outside the country. Wait times do vary by province. Then I showed you they vary by specialty. Canada's tax system pays for this. I mentioned earlier that it's very progressive. Basically, the wealthy are paying for the less wealthy in this system. And some people would say that's equitable. It's vertically equitable. Okay, is Canada's system socialist? That's a caricature, because I mentioned earlier 30% of Canada's healthcare, pharmaceuticals, vision, it's paid for privately. 70% of Canada's healthcare is paid for through government insurance. Well, what is it in the United States? Medicare and Medicaid and a bunch of other plans under Obamacare take up 50 to 55%. I mean, it really is a caricature to say we're free market and Canada's socialist. The main feature of the Canadian system is that there's no private co-payment, and that matters. Other features is you don't have a choice about what your basic health care plan looks like. It's what the province says it's going to be. There's cost controls on drugs, which delays access to new drugs in Canada. The Canada Health Act really discourages innovation in ways I mentioned earlier by constraining what the provinces can do, by constraining even what private clinics can do. And so you also have global budgeting, where the government says there's so much available for hospitals, so you get waiting lists because the hospitals can't pay for operating room time. They've run out of their budget. So you have operating rooms that are empty part of the year because the surgeons can't be paid and the nurses can't be paid. Okay, well, so what would the U.S. look like if it adopted the Canadian system? I won't go through all of this. Essentially, what this amounts to is, you'd have issue of who uncovered. No one would be uncovered. Everyone would have insurance. You'd have greater simplicity, administrative simplicity, a lot of regulation, but we're moving in that direction here. You'd free up resources from the healthcare sector to be used elsewhere, but the high marginal tax rates would discourage economic performance in other parts of the economy. Let me wrap up. Would Americans be better off? Well, if the goal is to have universal coverage, you can do it without adopting a single-payer system, and a lot of countries have, and we could do it here. We could do it with a lot less government insurance, and we can talk about the options in the question and answer. I'm going to wrap it up right now. But the model is to have vouchers. If you're really concerned about people who can't afford health care, then vouchers that directly enable them to buy private insurance would work. Where you'd get into trouble Where the rubber meets the road in Canada, when anyone starts talking about more private, less public, do you want everyone to have the exact same care? Can you live with a system where people who have more money can choose the best hospital, quote unquote, the best doctor, quote unquote, even though that system would probably make it better off for everyone else by reducing wait times? Some people would say, no, we don't want two-tier health care, and inevitably, if we're going to have that, if unless everyone starts out at the starting line with the exact same amount of money to spend, and even then it wouldn't be equal because some people are better buyers of health care than others. So, is it a good idea to have a single-payer system in the United States? My view is you don't need a single-payer system to accomplish the goal of universal care. We're better off having a system where we have people being able to buy competitively in the market, but you have to be prepared for cross-subsidies. Right? You have to have higher tax rates for wealthier people. You can't have a competitive system do that cross-subsidy. That has to be done outside the competitive system. So I'll take questions. Roger said that I should be the MC.
Yeah, go ahead. We have about 10 minutes for questions, so let's open it up.
So my question, because you showed costs per patient up there as the average, that didn't include, I assume, our initial insurance premium costs, correct? That was just the medical costs that we spent at the doctors, at the hospitals. So
well, the insurers are going to make the payment, so that's whoever makes the payment. That's the expenditure.
So that, yeah. The reason I asked that because, with the deductible, say $5,000, like a high level deductible, insurance is covering half of that. They're still paying like $12,000 a year for that insurance on top of the other five. If you were to look at the amount of taxes that are being put into the system in Canada versus the amount of private money being put into insurance here, on top of deductibles and other out-of-pocket costs, do you know of anybody who's looked at that as a dollar-for-dollar comparison?
Okay, well, let me make sure I'm on the same page with you. That expenditure number is it's whoever makes the expenditure, right? So it's not the insurance premium, but presumably the insurance company had to pay for whatever services were delivered. And in the U.S., part of that number is going to be out-of-pocket in payments that people make. So let's just keep it simple. For Canada, that number is all the money that's spent by the provincial governments on getting services delivered, the 70% that's basic care, plus the 30% that's either paid for through employer insurance or directly out of pocket. So it's not the amount spent on insurance, it's the amount that's spent on the delivery of whatever healthcare product or service you're talking about.
I'm old. My parents are older. My understanding is in Canada, the youth have better, faster, more care.
It's interesting because I did a student seminar in Calgary, Alberta, a couple of weeks ago, and I had quite a number of students complaining about how long it was taking them to see a specialist. Probably not for the same things that might worry your parents, but certain types of conditions that come with age, like worn out joints, you're going to wait longer. But if you were, well, okay, so we're all friends here. I can be candid with you, right? I mean, what I didn't mention in my talk, but I mean, there are all kinds of inequities in the Canadian system. If you're an Olympic athlete in Canada and you tear a ligament, you're not going to wait 8 months to see an orthopedic surgeon. You're going to go in right away. Um, do old people wait longer? Maybe they wait less because old people are probably more likely to be seeing doctors for things like cancer or heart surgery. So I know what's back. Maybe I don't want to impute this if it's inappropriate. I mean, what might be behind the question is, does the system give up on old people because we want to save money? And let's face it, the rate of return on keeping an 80-year-old alive another year is not so high compared to keeping a 16-year-old alive. By the way, just as an aside, some of these tests that are being done, called cost efficiency tests, to decide how much it's worth the government to spend on a new drug. The way they do this is they say, okay, how much more is it going to cost to use this new drug relative to the drug we're using? Let's say it's $1 million. Well, what's the value of that $1 million we're spending? Well, it's going to keep this person alive for one more year. Well, what's the value of that? You have to have an opportunity cost to do this test. And every government that I know of, other than the U.S., does this test. You need an opportunity, you need a measure. Well, in Canada, it's about $150,000. That's what you're worth to the Canadian government. It's $150,000. Private insurers in the U.S. have a much higher number. It's closer to $250,000. So part of what you're getting when you go to Canada is worthless. No, you're literally worth less than you are here. So stay here. You're worth more in the U.S. than you are in Canada.
I'm an orthopedic surgeon here in Spokane, and I've been in private practice most of my career. But I've also worked for the Indian Health Service and the military, which are our socialized systems. And what I found there was when things are triaged by inconvenience and wait times, that there's a lot of bribery and corruption. You find that's true in Canada? Are people trying to skirt the system by paying doctors and nurses and scheduling people? Is that a problem there, or is it being measured at all?
Canadians are angelic. That would never happen in Canada. No, it's, who knows? I have friends who are candid enough to admit to me that their fathers are doctors at VGH, Vancouver General Hospital, so they were able to get in quicker for a particular procedure because their father knew the surgeon who would say, I'll come in, and as long as there's a budget, I'll come in and I'll work a little extra, a few extra hours. I'm sure it goes on, but it's just no one keeps those days. If anyone keeps them, they're not revealing. The people who would have them in the government, it's not in their interest to reveal it, so I can't say.
This is a question for Dr. Globerman and also Dr. Stark. I'm a retired physician, practiced here in Spokane for 37 years, and I have a real concern observing the healthcare at the present time, that my concern is that down the pike in the future, a concern about how many individuals who are qualified to go to medical school are choosing medicine as a profession rather than going into another arena because of the educational costs and also because of problems in healthcare, such as the computerized healthcare systems, records, and I'd like your comments about how you see the future of training of future physicians.
Yeah, thank you. So there's no free lunch. That's the one thing economists know, and that's what they preach. If in this country, as we're starting to hear from the administration, there's going to be controls put on salaries earned by healthcare providers. We're going to have less supply of healthcare providers. There's no question. And what is different about Canada, one of the things that's different, is that medical schools in Canada are about 1/3 the cost of what they are here. I have a son who's graduating from University of Pittsburgh Medical School next week, and I'll be there. He'll be about $250,000 in debt, and that's with me helping him. And I advised him not to become a medical doctor because I predicted that we're going to have price controls in this country, and we may well. There's no question that there's going to be a big problem. And in Canada, there's an additional problem. The additional problem is residencies. There's limits on the number of residencies available. So my son has roommates who are Canadians going to U.S. medical school because they don't want to deal with the issue of trying to find a residency in Canada so they can practice medicine in Canada. But we're going to have cutbacks in residencies here too. Because the money for that, as you know, comes from the government. So, yeah, it's a big problem, and it'll be a bigger problem.
Let me also add that I think one thing you folks need to realize is the supply and demand from an economic standpoint as far as physician training is concerned. The government basically controls the number of medical schools that we have in this country. And so there's never been a free market for training physicians. I agree with Dr. Globerman that in the future, I think very likely we're going to see a shortage of well-qualified students. We haven't yet in the state of Washington. We can fill all the slots, at least at UW. I'm pretty sure at Wazoo as well. I was in Michigan last year, and the University of Michigan is only filling about 70% of the slots they have with qualified students. So we're not seeing it in the Northwest yet, but other parts of the country are, and your point is well taken. We have time for about one more question.
So, my name is Senator Fortunato, so I'd like to make a few statements, and I'd like you to respond. One, people don't buy car insurance to change the oil in their car or get new tires. Why do people expect health insurance to pay every time they go to the doctor? 80% of the claims that are processed by insurance companies are less than $300. So Whole Foods was on, before Obamacare, Whole Foods would pay their employees, give them a $2,500 catastrophic plan and put $2,500 in a medical savings account. Total cost of Whole Foods was something like $550 a month for a family of four, compared to $14,000 or $1,400 a month for a, quote, premium plan that paid everything. So in addition to that, one reason that healthcare or prescription drugs is cheaper in Canada is because they're using a one-generation older drug. Because I'm a U.S. drug manufacturer, I come out with a new drug. Where do I do with the old? The old drugs, they all go to Canada. So the new drugs have less side effects and things like that. So when you're buying a drug from Canada, you're buying in effect a 1 or 2 generation old. So comments on that?
Let me just say something, and thank you for mentioning that, because I didn't highlight that in my presentation, but I want to highlight it right now. One of the reasons Canada can spend a lot less on healthcare and not get wholly different results is because Canada free rides on the United States, as does most of the rest of the world. They free ride on our research and development for drugs. They free ride on our clinical innovations and new operations. That's a fact. And if we went to single payer, we couldn't free ride on ourselves. But no one else would be free riding us. We'd all go down the drain. So there you go.
Well, thank you very much, Dr. Globerman. This was a very well-balanced presentation. I think at the end of the day, bottom line is each and every one of us as Americans need to figure out what we see as the best healthcare system for us, for our families, and for the country. Thanks very much for joining us.